Welcome everyone. I'm Starla Lara, your facilitator for today's webinar. This webinar was organized by Swords to Plowshares and is designed for the grantees of the California Women Veterans Project and the Swords to Plowshares Regrant Program to gain a cultural understanding of the women veterans they plan to serve through the grant. Women are the fastest growing cohort in the veteran population, and over the next 20 years, women veterans are projected to double in ranks to an estimated 15%. Many women veterans are accessing care from providers in the community. Therefore, it is crucial for community behavioral health providers and advocates having a cultural understanding of the unique issues and experiences of women veterans. To help with this understanding, our guest presenter today is Elizabeth Stinson. Elizabeth is a licensed marriage and family therapist and the project director of trauma assessment. Elizabeth is also a member of the Portland Crisis Response Team, a military sexual trauma consultant for the Returning Veterans Project, a clinical advisor to the Bay Area Military Law Panel, and a member of the Portland VA think tank on military sexual trauma. Elizabeth holds a Bachelor's of Arts in Clinical Psychology from Dominican University and a Master's of Arts in Clinical Psychology from the University of San Francisco. She has extensive experience working with survivors of trauma and torture. Participants may type a question at any time to today's speakers or Swords to Plowshare staff. Simply type your question in the questions box to the right side of the webinar display. At the end of today's presentation, we will review the questions and comments posted. Kevin Miller, one of Swords to Plowshare's organizers, will be online during the webinar to provide technical assistance during the presentation. Please note that this webinar is being recorded. Without further delay, please welcome Elizabeth Stinson.
Thank you. Welcome all of you to this training. This is kind of a condensed training because it actually does take a lot of time and a lot of work to learn about military sexual trauma, but my goal here is to give you information on diagnosis, treatment, and tools that you can apply in your own practice with your own client base. It's not moving. Sorry, hold on one second. I did that. It's not moving. Okay, we're now moving along. Okay, basically that's been said, who I am. This is a definition of military sexual trauma. It's sexual assault and or harassment in the U.S. military setting. Either the victim or the perpetrator can be a member of the military. Often both parties are service members, most often. MST can and does occur both stateside and abroad. The DoD reports estimate that 86% of military sexual assaults never report their assault. No, and I'm talking about the survivor does not report that they've been perpetrated. And it's there's a number of reasons that I'll explain as we go through this. Survivors tell us that too often these assaults go unreported because seeking justice threatens their safety, their job security, and their future. The survivors I've worked with have told me it is a career ender and that they are the ones that had to suffer or had to get chaptered out or for a number of reasons. And I think that this comes from my own personal experience listening to all these stories from client after client, is the expectation that after someone has been sexually assaulted, whether they file a restricted or an unrestricted report, that they'd be able to be battle ready and follow commands immediately, and that's just an unrealistic expectation. Women make up about 14.5% of active duty military personnel. More than 800 women have been wounded and more than 130 killed in fighting in Iraq and Afghanistan. The linear battlefield no longer exists. It is alleged that women are engaged in combat even when it's not part of their assigned roles. More than 200 women have begun reporting to maneuver battalions and combat teams. Sexual trauma is unique in the military setting, both during peacetime and war, for several reasons. And this is critically important for clinicians to understand, because even those of us with a lot of experience treating sexual trauma in the civilian population have to understand these differences. Survivors of MST commonly live and work with their perpetrators during and after their trauma. Many survivors are dependent on or report to their perpetrators. This power dynamic makes it difficult to report for fear of retribution. Sexual assault by a superior is commonly called command rape. A survivor, male or female, faces serious stigmas for reporting assault or harassment. They may not be trusted by their counterparts and are often accused of breaking unit cohesion or are harassed by others for sexual favors. A survivor's military career may be extremely affected when they report harassment and/or assault. The stigmatization that happens after reporting command rape and other forms of MST often lowers the possibility of advancement in rank. Survivors have been encouraged to remain silent in order to keep their careers. It's a public health issue. Sexual assault and harassment have only been documented in the armed forces since 1988. Military sexual trauma has been directly correlated to the development of PTSD and numerous mental health concerns such as anxiety, depression, and substance abuse. The impact of all of these things on the family system and the community system are really take a toll, and the fact that they affect the wage earners and your ability to earn a wage, your ability to function, your reactivity. We can't assume that all people who have survived MST have PTSD. There is a trauma spectrum of symptoms that we have to watch out for. Violence against women choosing to serve in the armed forces is a public health concern because of that domino effect. It affects the family, it affects the community, it affects the degree of function within the family and the community, and the ripple down effect. Women who are raped or assaulted while on active duty are more likely to report chronic health problems, prescription medication use for emotional problems, failure to complete college, and annual incomes of less than $25,000. The spectrum of trauma-related problems is really the social toll. The psychological response to MST often includes a cluster of symptoms that interfere with function. The combination of sexual assault and combat exposure greatly heightened the psychological injuries in veterans of the wars in Iraq and Afghanistan. MST is a unique form of betrayal trauma. In order to understand what I mean by betrayal trauma, imagine that you have been trained next to the person who assaulted you. You have the same mission as the perpetrator. You're both subject to the same rules under the UCMJ, the Universal Code of Military Justice. You may be battle buddies. In many cases, the perpetrator may have a higher rank. The levels of betrayal are deep. Needs for psychosocial rehabilitation are intense. Psychosocial response to MST can cause significant impairment in life-functioning domains such as family relationships, career and work relationships, interpersonal and romantic relationships. Few marriages survive an MST incident, and friendships get shattered. MST has been known to seriously impair survivors' ability to emotionally self-regulate. Clients report that minor obstacles and stressors are often perceived as being overwhelming, like taking a bus, public transportation, all kinds of things that are similar to some of the responses with PTSD, but with MST, proximity to, like say you were assaulted by a man. Proximity to a man, an unknown man, might bring another threat. Within the spectrum of trauma-related problems, most often the anxiety response is seen in the survivor who has had little relief or support. Symptoms your client may have can often present as body dysmorphic symptoms, correlating with isolation, withdrawal, and agoraphobia. And those are pretty systemic in that order. If you have a body dysmorphic symptom because kind of you perceive yourself differently, like you look down at your body, you're going to see something different than what actually exists. Often that results in cutting and other self-abusive behaviors. The symptom of isolation includes the progression into more withdrawal from family, withdrawal from social community, and many, many MST survivors go into full-blown agoraphobia where they're unable to leave their home. We've worked with a number of survivors. Everything I know I learned from my client base, and they talked to me about, you know, the hopelessness that they felt when even trying to deal with these severe anxiety symptoms and not being able to find the support within their communities or within their families. Masking is one of the symptoms that I look for as kind of a progression symptom, because it's also a way for your client to hide themselves. Your client does not want to appear as the same person as the person who was assaulted. Your client will often work to radically change their appearance. You may often see changes in hair color, weight, clothing, overall appearance. Tattoos and piercings, as much as I love them, they are very common. And if you see them suddenly appear on a person who has not shown any interest in anything like that, and you kind of have to look at it as maybe this is something you need to explore. Are you trying to hide who you are? Are you trying to change who you are? Are you trying to affect the way you appear to others? And look at that symptomatically. Agoraphobia is an anxiety disorder that results in fear of places, crowds, and or being in places you cannot move easily and quickly from. People with agoraphobia often struggle with being in a public or crowded place. There's fear of being in a situation in which you have less control. Your client may have to face the door of your office or be seen in their home. Public transportation is often an issue, as are family expectations. I'm not going to that birthday party. I'm not going to that baby shower. I don't ever want to have a baby. Those kinds of responses that they're unable to excuse me, express to their family member, but that's their feeling. But they can tell you, their support advocate. They can let you know that they have those feelings. Body dysmorphic disorder are false perceptions of all or part of one's body, causing obsessive responses, eating disorders, cutting, picking, hiding, masking. Trichotillomania is actually a very common response to MST. It's an impulse control disorder in the family of body dysmorphic disorders, causing obsessive hair pulling from head, eyebrows, or the pubic region. I had a client a couple years ago where just kind of spontaneously one day I asked her about different body images, and she flipped her head to the side and showed me that half of her head was completely bald from having pulled out the hair. And she had long hair, so, you know, for her to be able to hide that for that much time. And I remember thinking, you know, why did I ask that question? What stimulated that question? Because I was just kind of going through the whole body check of how, you know that we feel trauma in our bodies, that often our first signal that we're feeling traumatized is a tightening of the chest or rapid breathing or a cramp in the stomach. And really being able to teach your client to do a body check 2 or 3 times during the day helps them get in touch with how they're feeling and how they're responding. Symptom clusters can include self-hatred, numbing, depression, aggressive behavior towards self or others, dissociation and depersonalization. Dissociation is especially important because sometimes you dissociate so completely that you're out of your body looking at yourself from a distance. That's not a safe place to be if you're trying to take care of a child or driving a car or make a work-based decision. Impairment in capacity to enjoy activities and intimacies formerly found pleasurable is very common with your MST survivors. So helping them reintegrate into a new system of things that they enjoy is a big part of the support that you offer. VA material states some problems associated with MST include disturbing memories or nightmares, difficulty feeling safe, feelings of depression or numbness, problems with alcohol or other drugs, feeling isolated from other people, problems with anger or irritability, as we've already discussed, and problems with sleep and physical health problems. When I saw this on the VA pamphlet, I was wondering how many clients will actually follow through if they see themselves within this category. So I think for those of us, whether we work for the VA or for other organizations that advocate for MST survivors, just being able to do this kind of intake questioning is very important, especially if you have someone who is self-isolating, then the likelihood that they're doing self-harm is higher. MST is also known to stimulate body-focused repetitive behaviors. These can include skin picking, repeated touching, scratching or rubbing. BFRBs are considered both impulse control disorders and affect regulation disorders. They can be very important, and they're also signs that the anxiety is not being managed and the coping mechanisms are not being developed that your person needs in order to support themselves personally. The International Society of Traumatic Stress Studies also recommends in treatment of PTSD that interventions should be culturally sensitive, developmentally appropriate, and related to the local formulation of problems and ways of coping. This slide is particularly important to me. I'm Anishinaabe. I'm from a tribe up in Canada, and I can tell you how many trainings I've done that have felt like they were geared towards just one singular population and didn't take into the fact that there has to be a knowledge of the diversity of your client and what they can accept to respond. Because otherwise any intervention you give them is not going to land. It's not going to be used unless you understand where they're coming from and what their value system is based on and how they would develop a coping mechanism that you could support. Your client has been trained to be aware of his or her surroundings and to maintain a defensive position and may maintain a highly aroused and nervous emotional state. Your client may have had to maintain this emotional state for far too long through many deployments. Your client may need to learn with you how to relax their symptoms and experience that relaxation and safety with you. You may be the first person that can offer them that space. These are things to be mindful of from a veteran perspective. Are you a veteran? If not, are you familiar with military culture and terms? Note your office decor. How personal is it? Look at your pictures, family pictures. Are there military references? Is your office a trigger? These are things you can discuss with your client. If you have something in your office that for some reason unknown to you is triggering something in your client that's going to possibly make them not want to return, you want to know that. The following are treatment recommendations based on experience treating military sexual trauma survivors. My clients are both male and female who are either active duty or post-discharge from the military. Most important is the building of your therapeutic alliance. Do this with great care. Begin with a very thorough assessment. Many who are treated for MST have not been properly assessed for PTSD, depression, as well as a traumatic brain injury. It is advised that you do not order tests, evaluations, etc. without thoroughly discussing options, procedures, and locations with your client. Every step of your process must have the goal of the client's recognized needs being met willingly. Your client's ability to build trust will parallel reconstruction of their self-empowerment. MST is not about sex. MST is an abuse of power. Explore meaning of safety with your client. Explore triggers. Explore your client's ability to self-resource. Work with your client to develop and implement his/her treatment plan. Therapeutic objectives. Establish concrete but broad goals as soon as possible in union with your client. Explore client's awareness of emotional responses that help your client. I say broad goals because if you establish specific goals that are small, that are undoable, your client will experience failure and will kind of set a stage for themselves that you don't want that to happen. So you want a broad goal that's a very doable goal that your client can feel some success from. Explore what does more damage than good and why. Reinforce with your client the value of his/her narrative. This to me is the most important thing. I don't care what the family thinks, what the government thinks, what anyone thinks except for my client about their situation. It's how your client feels and thinks and values their experience that you have to relate to. Know that you are working with a survivor, not a victim. Value all their defense systems, even those that seem a little destructive at first. Value it and work with them to find more constructive defense systems. They're there for them. Work with your client to replace destructive defenses with very positive ones. And you can do that very subtly but honestly with your client. Like if your client is prone to drinking a little too much to the point where they're endangering themselves again repeatedly, you want to work with them on kind of monitoring that. Make that one of the checkpoints that you're doing in your sessions and when you meet with them, and work to bring that down and replace it with something more productive that they can do that's less likely to put them in a dangerous situation. Treatment is counterproductive if re-traumatization occurs. This is especially important to me because, as you know, the VA and many of the organizations, the money's gone into treatment modalities for PTSD. And one of the treatment modalities that has the most evidence-based process proof is PE. So, you know, when you're asking someone to expose themselves over and over to the trauma, the personal exposure trauma, you don't want to do that with your MST person. You want your MST survivor is going to be re-traumatized. They have a rational fear. They have been traumatized. They don't have to experience it over and over again. Where you can use personal exposure therapy with your client is something like if they're afraid of the dark, if they're afraid of going around a dark corner, you know, and working on just natural things that you want them to be able to do, that they want to be able to do. Systematic desensitization and exposure therapy can run the risk of further traumatizing the MST survivor and should be used very carefully and with trust at the place the client needs. And by the place, I mean at the pace the client needs, I mean move with the client. Don't move ahead of them. Don't assume that, okay, this is what my client needs to be able to do in order to get to work safely. Ask the client, your client, do you feel unsafe getting to work? Do you need some help planning how you get from point A to point B? Would you like some ideas? You know, give them, empower them. Don't disempower them. That's your goal. Work with your client's narrative in the present moment. Support the building of their psychological safety. Your client's fear response is rational. You can best support your client by exploring with them their emotions and reactivity around their fear response. Exploring your client's reactivity when they are feeling safe can help to diffuse a destructive emotional and ruminating response. By ruminating, I mean repetitive, over and over, when they're way out of the danger zone, but they're still re-experiencing it in their mind and having ruminating thoughts, reoccurring thoughts of the response. And that increases their anxiety, builds their fear around what they're trying to accomplish. Your client will naturally and repeatedly reprocess their trauma. How and when must be up to them. The ability to process unexpected stimulus of traumatic memory is one of the primary goals of therapy for the military sexual assault survivor. Increase in these strengths will support your client, increased ability to self-regulate, and their ability to self-regulate is your goal, so that they can control what they can do and how they feel in their daily struggles to have a normal life. Imagine your client is the surface of what happens to be a three-legged table. What happens if one table leg is missing? One of these legs is their ability to self-resource. That's what they bring to the table. What are their coping mechanisms? What are their strengths? What are the things, their interests? What gets them to, and stimulates them to move towards stability? The second leg is their supportive family and friends. The third leg is your community resource, and that includes you. You are a big part of that third leg.
Hi, Elizabeth.
Without one of those, you'll fall over.
Hi, Elizabeth.
Yeah.
Hi, this is Star. We had one question that I thought we can discuss now while it's timely, and it was, if PE is counterproductive, why is it being used as a default treatment within the VA?
Well, I'll be honest with you. I'm part of the military sexual trauma think tank up in Portland, and PE is taught over and over again, and it is effective with PTSD. And most of the money and most of the research has gone into the treatment of PTSD, because the bulk of clients that go to the VA suffer from PTSD. MST just, really in the last decade has become something that, and is particularly in the last 4 or 5 years, that they've had to pay attention to. And prolonged exposure therapy can help desensitize the MST survivor on many levels if they're if you're working on specific things that they're unable to do. I can't go out in my car. I can't drive safe. I don't feel like I can drive safely without being triggered. Those kinds of things. You can help support them in their day-to-day activities, but you don't want to re-traumatize your client by having them re-experience the trauma of their assault over and over again. Whenever they want to talk about it, you want to hear it. But when they don't want to talk about it, you don't want to push it. Work on other strengths and developing other strengths. And I can't personally answer why the government sets up or funds certain protocols. I can only tell you that from my client base and what I've learned, that you run the risk of re-traumatizing your client by using prolonged exposure therapy in the wrong way. You want to use it specific to what they're trying to do, that they're struggling with, that is going to keep them from self-isolating. I hope that answers your question. Okay, so how does your client reach self-resource? How does your client identify and communicate their needs? What areas of need require strengthening? Personal resourcing? What are client strengths and how are they helping? These are things that you're going to assess often. It's not like on your first intake that whatever the answer is then is going to be the same as it is 90 days later. So you want to pay attention to how they're responding to their therapy and how they're responding to to whether or not they're meeting their goals. Familial support is very, very important. If it's there, use it and work really hard to make sure that it's being supported on all levels, because I can tell you I have clients who are third, fourth generation, fifth generation military who were completely rejected by their families because that was not their family's experience in the military, and so they were blamed for the experience. And I have clients whose family members were military who totally stepped up and supported them every step of the way. So really looking at the familial support is of value. Community building helps build safety for your client. So encourage them to get involved in things in the community that they're drawn towards, even though they may be afraid. You know, help support them, build alliances. It's very important for their mental health.
Hi, Elizabeth.
Yeah.
This is Star again. I have another question, and I think that it piggybacks on the previous question, but I just want to go ahead and bring it to light. It says from Jessica, what do you do for a client that went through PE treatment for MST and was re-traumatized by it?
That's a really good question. Thank you, Jessica. I actually have had to deal with this, and that's why I feel so strongly about it. When you have a client that's re-traumatized, you're dealing with complex trauma, complex PTSD, because it's not something, it's not at that time a singular event. It's a dual event because they tried to express it in their community in a safe environment, and they've been re-traumatized by it. So it's really important to identify the complexity of it, and it's a good window for you as a clinician or a support person to move into, rather than away from, move into it to help find out what the triggers were that were intolerable. Because you can only work with what the client can tolerate, and you can only nourish what the client can tolerate. Acceptance and commitment therapy is a mindfulness-based behavior therapy and was developed in the belief that ongoing attempts to get rid of symptoms may create more stress as well as clinical disorders. This kind of piggybacks on our discussion about PE, because what I want people to understand that we've learned through mindfulness-based treatments and through meditation and acceptance and commitment therapy is that building safety in the moment with your client is critical. Because if they don't feel safe in that moment in your office with you, if they can't calm their reactivity with your support, then it's very unlikely they'll be back. You want to be part of their healing process, not part of their re-traumatization. We are incredibly restorative human beings. We go through all kinds of stressors, and if we're able to slow everything down and hold it steadily and accept this moment as a safe moment and really commit ourselves to our life healing, we can make incredible progress. ACT has been proven to be quite effective in working with survivors of trauma. The traumatized client often struggles with states of hyperarousal that interfere with executive function. Helping them relax and helping them be mindful of the safety of the moment helps them strengthen, and also it helps the brain synapse in a calmer way. The timing and location of neural activation directly correlates with the timing and characteristics of mental activity. There's an interconnection between brain, mind, and relationship that stimulates neural firing patterns in the brain. By practicing mindful cognitive awareness with your client, you support their growing self-management. In essence, if you help support their management, you are also supporting their neural firing in the way their brain synapses. I usually start with like 5 minutes in a session and ask the client, would you like us to take 5 minutes, and we're just going to sit here and we're going to focus on your breathing, and we really on the person themselves and how they're feeling, trying to be really still and quiet and aware. It's a process of observation and attention in the flow of changing stimuli and perceptions. And that can be the first time your client has experienced this. They've been in a hyper-aroused state. And for them to be mindful of the safety of the moment, present in the safety of the moment, is an engaged state of awareness. An important characteristic of a mindful state is that it's free of judgment. Also, mindfulness is not a passive state. We apply intention when we're mindful. It takes work. We know that outcome and process cannot be predicted with the use of mindfulness because mindfulness is the process. You can support your client's ability to be present in the moment of now with safety as their center. The impact of mindful relaxation on their nervous system is the needed outcome. One of the benefits of mindfulness is the growing ability to self-regulate. This practice supports your client's ability and sense of self-mastery. You'll see it on your client, and check in with them often, because if this is not the route they want to go, you want to use another modality. There are a number of ways to practice mindfulness in the session. We already talked about this just now, about practicing with the breathing. Ask your client to sit quietly, focus on their breathing, and as things come up, ask them simply to name it and lay it down. It's kind of like putting it on a psychological shelf for a few minutes while you relax. Things come up, they name it, and they lay it down. Things come up and they lay it down with the next exhale. Psychologically putting them down and returning to focused breathing. Afterwards, you check in with your client of all the things they laid down and say, what of any of these things do you want to pick it up and work on it or examine it with me? And if they say, I'd like to look at this, great. If they say, nope, I don't want to look at any of it, that's great too. Move at the pace that they can tolerate. Honor and help your client explore their range of feelings. And I'm going to skip this slide because I already talked about the 5-minute process and setting the thoughts down. Often with working with survivors of abuse and sexual harassment, there's a lot of emotional reactivity to the concept and practice of laying down your fears. And this is critical for you as a clinician to provide a safe space for them to do that. The fears and the pain will resurface repeatedly, whether they're with you or away from you, and you want them to know the feeling of safety. Your client's been spending a lot of psychological energy defending themselves and has adopted a structure. Initial relaxation of the structure also involves relaxation of some of the constructed defenses. In processing this, expect emotional reactivity. This is good. They are feeling something new, and it can be frightening. It is the undefended self they can access to begin healing. The work of Dr. Daniel Siegel on mindfulness in the brain teaches us that neuroscience studies and subjective experience of mindfulness together demonstrate that non-reactivity and emotional balance go hand in hand with the ability to label and describe internal states. We learn that what before felt like an unchangeable and distressful feeling can now be observed and noted, and we can come back to equilibrium more readily. This is the essence of a resilient and effective style. These are tools you can explore with your client. Narrative therapy is especially helpful because their story is what matters. Working with the survivor's narrative can be very effective in reframing responses to experiences when a goal is set by the client of not feeling defined by the trauma. EMDR is effective. Many clients respond to it, some don't, but it can reduce the charge felt when triggered by traumatic recall. Transcendental Meditation, focusing on an image or word or mantra that evokes a feeling to transcend, move away from the anxiety, can be helpful. CBT is effective for the treatment of a variety of conditions, including mood, anxiety, personality, sublimation eating, which is common with MST survivors, as is anorexia and bulimia. Often their anxiety will manifest in an eating disorder, substance abuse, tics, and by that I mean twitches, and psychotic disorders related to trauma. CBT was primarily developed through an integration of behavior therapy, first popularized by Edward Thorndike with cognitive therapy, developed by Aaron Beck and Albert Ellis. While rooted in rather different theories, these two traditions found common ground in focusing on the here and now and alleviating the symptoms. Your client may be unwilling to bring charges against their perpetrator. In military sexual trauma cases, you as the clinician or advocate cannot make any guarantees about how your client will be treated, either by the military or by, I wrote that twice, or by the civilian judicial process. Self-examination, how you feel. You as their clinician can support them through their process, whether they choose to report the abuse or not. And I say this because in groups with other clinicians, I've seen the frustration with when a clinician has a client who won't report the abuse because they feel like this is unending. It'll never end unless everyone reports. Reporting options, which are hopefully changing rapidly, right now are still restricted and unrestricted. A confidential reporting method that allows a service member to disclose to a specified official that he or she has been the victim of a sexual assault. The victim receives access to medical care, counseling, and advocacy without requiring officials to automatically report to law enforcement or initiate an official investigation. In my experience, that often leaves the client in a dangerous situation. Unrestricted, when a victim reports on an incident of sexual assault, the matter is referred to investigation and victims' rights apply. Victims may receive health care, counseling, and advocacy services. However, details of the incidents are reportable to command and law enforcement. I know further in the summer they're having a session on law, and they'll cover much more of this. When the assaulted person is a member of a reserve unit, local law enforcement authorities can and should be notified. I come from a state where there are no bases, but it has one of the highest numbers of deployed reservists in the country, and them finding the right resources is very important. A client emotionally supported is less likely to self-medicate destructively. Help your client assess their family, social, and work relationships. You may want to explore clients' function level prior to service in order to establish appropriate therapeutic goals. When I say that, I mean you do not want to be working to aim for something that's undoable or is going to just lead to frustration or failure for your client. MST survivors often describe experiencing involuntary flooding. This is also a PTSD symptom. It's described as a sense of overwhelm with traumatic memories, accompanied by what may feel like disabling emotions. If flooding occurs in session, move into it, not away from it. Be mindful of what the client's experience is. Use guided imagery and breathing to bring your client into the present safety of your session. Your traumatized client may experience involuntary flooding with or without you. You can help your client develop the tools needed to move through and beyond this reaction. Often MST survivors are in need of medication in order to manage symptoms. Know that medications your client has had and the effect. Support the transition to different medications when necessary. When a client or caller is an MST survivor, it is important to connect them with the support they will need to implement personal safety and avoid unnecessary punishment for time disabled by trauma. Your client may qualify for a medical discharge or a higher disability rating following discharge. Making correct referrals for support is critical. A thorough assessment can be very valuable for your client. And I encourage the clinicians that I train to treat MST to do the initial intake assessment, but then after 90 days or to 120 days of treatment, do another assessment. You want to really gauge what's working and what isn't. A clinician can offer psychological support as well as referrals to appropriate support, like SWAN, Service Women's Action Network, Swords to Plowshares, of course, as well as work with counselor, client, and attorney to generate reports needed to advocate for the client with the military or the VA. And this is particularly important for people to understand because a lot of clients who end up being referred to me have already seen a number of clinicians who have recognized their trauma and their degree of trauma, but because they're employed by the government, possibly, or because they're in some kind of service-related process, they are unwilling to generate the paperwork reports that the client needs. So it's really important to get those referrals to them so they can go proceed and get their disability rating changed if it's needed.
Hi, Elizabeth.
Yeah.
We received one question from Joanne. What are your thoughts on difficulties referring to patients' compliance and medications?
Well, those difficulties can kind of run the gamut, and I think it's really looking at what's connected to their noncompliance. There's going to be some behaviors. There's going to be some something going on that is either they're having trouble with the medication, it's the wrong medication, or they're having a problem with how they feel on it and whether or not some part of them. I had one woman recently describe to me after a med change that she felt like a rubber eraser, that's how she felt, and she couldn't bring herself to take the medication because she felt like it distanced her too much from her child. So I had to work with her PCP, her primary care physician, who was her prescriber at the time, about different options. I'm not a doctor, so I cannot give medical advice, but I can tell you that as a clinician, we need to recognize when they're non-compliant and try to find out why. What is it about it? I mean, some of these antipsychotics and antidepressants are very, very hard, and it can be a very, very strong cocktail of medications. So we have to respect what our client's experience is because it's going to be different with each person. I hope that answers your question.
I think so. She had actually another question.
Okay.
Are there resources for civilian health providers to assist with the service-connected language?
That's a really good one because what I did when I started like about a decade or so ago, I made the big mistake of going on the DoD website and telling my printer, my computer, to print out all the acronyms. And I got back something bigger than War and Peace. Actually, it was that thick. It was pages and pages and pages. And you need to know what your client is talking about. But there are certain things that you need to you're going to hear more often than other things. But it's really research. It's there for you. If you want to know, it's there for you. You can Google it. You can look it up. Ask your client if they say something that doesn't. If they say, "Oh, my MOS just, was impossible. I was the only woman." Blah blah blah, whatever was going, and you don't know what they're talking about. Ask them, and they'll explain to you what the acronym they're using. But it's very helpful to them if it doesn't interrupt their flow, and you can proceed with the session knowing what they're talking about. But if you have a question, ask your client. Let them explain to you, because in their explanation, they're going to become more grounded, and they're also going to understand that this is not an assumption, that you're not assuming that you know everything that they know, that you actually need them to teach you. Hopefully that answered the question. But it is there. You just Google it if you have a specific something they're asking. You know, the information is there, and ask your client if you can't find it easily. Especially if it reoccurs, if they mention something over and over and you don't know what the heck they're referring to, then you want to do that with your client. Find out, because that's an important thing that they're addressing personally. Okay? So alterations in relations with others is one of the symptoms, and this is where we're back to the isolation and withdrawal and disruption in intimate relations. There's a repeated search for a rescuer. This is an unconscious goal of many MST survivors, and it can alternate with the isolation and the withdrawal. There's no rescuer. You know, so often that's projected onto the therapist or the clinician. So you really want to pay attention to that and not build their dependency on you. You don't want that. You want to be supporting their independence and their ability to self-regulate and cope and pull these things up when they need them. There's persistent distrust. You may feel really bonded and attached to your client, and then have the next session, them come in and they're angry with you, they don't trust you, they don't want to tell you anything. And it's a really good opportunity to find out what their weekly experience that disrupted them was. Repeated failures of self-protection is also common. Alterations in systems of meaning, loss of faith, sense of hopelessness and despair. And these lead to severe depression and sometimes to suicide attempts. These are some of the resources. Returning Veterans Project is actually an Oregon resource. SAPRO pages can be used for DoD reporting options and guidelines, as well as to reference published reports. SWAN has a helpline. For up-to-date policy papers on MST, consult Swords to Plowshares and Iraq and Afghanistan Veterans of America. These are more resources, and these are the websites, and you'll be able to find these online if you can't click them from where you are. It's important to have these. There is a list of rape crisis centers near military bases, and I cannot tell you how disappointed I was in that list. I thought that it would be much more comprehensive, and I did phone a number of the rape crisis centers, and I just thought that there would be many more of them, many more resources, especially again around bases where there are systemic problems, where we get a number of MST reports. But the ones that are on the list are very good and good to respond to. They will get right back to you. Several community organizations have free retreats for service members and veterans. Check out Vets for Vets, the Coming Home Project, and Outward Bound. Veterans for Common Sense is really good with advocacy and policy, as is Swords to Plowshares. TAP, Trauma Assessment Project, that's our project, and we work with MST survivors, and we work with people who have a disability rating that they're unhappy with or it doesn't fit them. When we meet with them, it's obvious that they have a rating that needs adjusting. And then Swords to Plowshares. This is a really important piece for everyone. Everyone who's online listening to this. Secondary trauma is a reality. A good therapist or advocate cannot hear MST survivor stories without empathetically feeling a great deal. You're working with a very difficult and hard to process issue. Be sure as you don't take on more of this work than you can handle. You also balance it with your own self-care. It can come in flurries. A few years back, I had like 7 guys who were all victims of what are called blanket parties at one of the bases, and had been sexually assaulted and had all gone AWOL within a 24-hour period and somehow contacted us. And so you can get flooded with like, oh, this is more work than I can handle. So you want to take care of yourself through this. Don't everything we need to do for the MST survivor, we also need to be able to do for ourselves. We're not limitless in what we can manage, and taking care of ourselves is important. Seek counsel when needed. Brainstorm with other therapists. Call me, call Returning Veterans Project, call Swords to Plowshares. You definitely counsel others. Exercise, eat well, stay rested, and please use what restorative measures you need to keep yourself replenished. Those of you who are working with survivors of military sexual trauma are helping to strengthen and bring compassion to the country's system of psychosocial counseling, promoting much-needed individual and perhaps national healing from this shared trauma that impacts us all. And we really want to thank you for your efforts. Okay, if there aren't any more questions, I'm going to talk for a little while about some of the cases that I've had, because I think that it's important to know what goes on out there and what kind of things you're going to be approached by. I've had a number of situations where I've had people referred to me after they've made 1 or 2 suicide attempts. And that can be especially traumatizing to a therapist who hasn't dealt with suicidal ideation, let alone suicide attempts. And they're talking to someone who has the means, has a plan, and is, has every intention of carrying it out. So it's really important for all of us as advocates and clinicians to know when we need to do something, like involve. If someone is actively like on the way or on a bridge ready to jump, or has a plan and an action that's a lethal plan, and you can't talk them down, you need to involve resources. You need to let police know. You need to, up in where I live, we have a mental health team that we can send out, but we don't send them if the person is armed. We send them with police backup. But not every city has that. But we're part of, you should know that there is a 5-city, 5-year program that's putting mental health clinicians in between suicidal and homicidal people and the community. And so the first responder is a mental health clinician. And we're hoping it becomes a nationwide model if it's proven to be successful. We're in the 3rd year of it, and it seems to be a viable answer for suicidal and homicidal people. But mainly I'm working with veterans. I work with veterans who are feeling increased hopelessness, coming home, having trouble reintegrating into their family, reintegrating into their city. Their community has changed during the war or while they were deployed. And it's really important to be able to assess for all those risk factors and to not let your client, if you're afraid of your client, if you're afraid of what your client's story is, what they've come to tell you, they know. They're feeling it. When you're in a state of hyperarousal from PTSD or from military sexual trauma, you're going to feel it. You're going to feel it in the vibration and the energy in the room. It might confuse you what you're feeling, but you are going to be very, very sensitive to it. And you as the advocate or the clinician need to be aware of that. and be able to address that so that you can
Hi.
help the person calm down.
Hi, Elizabeth. We do have another question. It's, what is the difference between male and female survivors of military sexual trauma?
What is the difference?
What differences do you see?
Oh, well, you mean from a clinical perspective, like how I would treat them, or how what they have to deal with because of stigmatization? I mean, there are many. There are many differences. Let me talk about a couple of them. Most of the males that I have counseled who went through military sexual trauma did not report it because they feared stigmatization and they feared what that would do to them overall. Most recently, I worked with a young man who did report it, but did a restricted report, and you know, his family still fell apart, and it was very, very hard. And because he did a restricted report, the sources that he chose to speak to didn't hold up their end, and he ended up feeling very, very isolated. And if you file a restricted report, it's limited who you can talk to. So I do find that more with males. Many females file restricted reports also, but I would say the biggest difference is the stigmatization, because women are unfortunately objectified as sex objects often. Men aren't usually assumed to be objectified in that way, and it's a double shock. It's a different degree of betrayal trauma, and I think it confuses on many levels, because for men, at least the men that I have counseled, I can't speak for all men, they have not been willing to report it, so they've been unable to get the support they needed, and often it left, because the reality of it is, even though the person doesn't report it, the perpetrator will often brag and get, a drink or whatever and announce what they've done. And other people know. It often doesn't happen in isolation. There are other men involved. It can be very brutal. So I think the big difference for me, and I can only speak for my client base, the big difference for me is their ability to find some support fast, to get some support fast, because they can't turn to their battle buddy and say, this happened to me, and get support. Where a woman or most of my clients who were sexually assaulted who were female were able to turn to another woman and get some support. So I think that is the primary difference, is that they have less support because they get so heavily stigmatized. Any other questions? How are we doing here? Okay.
Hi, Elizabeth. Yep,
Hi.
there aren't any additional questions now, so you can continue telling your story.
Okay, so let's see. You know what? This might be a good time to talk about a male sexual trauma that that was particularly moving to me. I actually, for a while, for an unfortunate number of years, my phone number was on the Greyhound bus station wall at Fort Sills, Oklahoma. And so if people went AWOL from Fort Sill, they would walk along the train tracks, get into town, and then wait for the next Greyhound bus. And Fort Sill would routinely run jeeps by there to see if there were people trying to go AWOL, but they would miss a lot of them who would catch the bus. Well, in the Greyhound bus station was, if you need help, call this number. So I would get these obscure phone calls from Oklahoma, which, by the way, I think I've been to Oklahoma once, and I was 7, so I had no idea why they got my number. So what happened was I got a call from a young man who had just gone AWOL from Fort Sill, was heading up to Canada, he thought, but he was actually going in the wrong direction. He was very, very traumatized. He had gone through a really bad experience at another base, but had been sent to Fort Sill for another. He'd gone through his basic training where he had been traumatized, and he had been sent to Fort Sill for his AIT, or what I think that's why he was there. It was his second phase of training, and his trauma had kind of followed him, not the actual perpetrator, but the story of the trauma. And so he was being sexually harassed quite a bit. And he was suicidal. He had a plan, he had a means, and he had an area where he thought he could safely end his life. And when he called, he told me probably 20 times, there's nothing you can do to stop me. This is what I'm going to do. This is what I'm going to do. And I said, well, for some reason, you called me. Can you tell me what I can do for you? What did you need that you dialed the phone? And he just, fell apart. He was quite emotional. And I said, I'm so glad you called. Thank you. This is really, really good. Now let's see what we can do to help you. You're not alone. You're not alone in this at all. And you're not the only man this has happened to. And that was like a shock to him. He was stunned to find out that he wasn't the only man that had experienced this. Of course, this was before a lot of the numbers were released about male sexual trauma in the military. So, it was early on, and he was definitely in a state of shock and in a deep despair. So that was an experience where he had self-isolated, and I happened to know someone at Fort Sill that could have helped him had he contacted me from the base. But he didn't. He contacted me after he left. So he did survive. He is okay. Bottom line is, but it's just it does piggyback onto how the male responds. There's a lot of shame. There's a lot of shock. And it's really, really hard to come to terms with. I've had people I also had a client who was in a military hospital, hung himself in the military hospital in a deep state of despair, and was tased by the hospital staff before they cut him down. So, and that, when I talk to you as clinicians and advocates about taking care of yourself, that's what I mean. You really want to take care of yourself, because I have reoccurring thoughts about this young man that I worked with, because he did go through this terrible experience. And I called the hospital the next day as soon as I heard about what had happened, and I said, why was he tased? How could you do that? He was hanging. Why wasn't he just taken down? And they said he was flailing around. He could have hurt someone. And to me, that was ridiculous, and I was really upset about it and filed numerous complaints. But the reality of it is, we don't have control over what happens to people in the military. We only have control over how we support them when they contact us. And hopefully that we'll do more and more, and we'll unite as support advocates and support groups and stay ahead of the information and really provide a safety for MST survivors, male and female, so they can deal with this trauma.
Hi, Elizabeth.
Yeah.
We do have a couple more questions.
Okay.
And this one is from Joanne. How can family members who experience secondary trauma be more involved in the client's treatment? What resources would you suggest for family members?
That's a really good question. Can I ask Joanna what area of the country she's in? Where is she?
Joanne is in the East Bay, out of Alameda.
She's in the East Bay. Okay,
yes.
That's great. That's great. Because there's in the Bay Area, there's a group called Therapists for Social Justice, and you can, I'm trying to think of who runs it now. I can't think of, I think they have a new person, but it's a group of therapists that are really aware of what happens to people who are involved in combat and go through deployments, and they do all kinds of work to support people and their families. And I would really look for a systems therapist, a family systems therapist, a marriage and family systems therapist. Not because you want, marriage is a component of anything, but because a family is a system. And the person in the family system who shares the trauma makes a conscious choice. I am here to support you, and I am going to share this trauma. You can tell me this, and I am here for you. In doing that, they also can become traumatized. So because of that, they have to work harder to strengthen themselves so that they can also continue to be support for the person who's traumatized. I cannot tell you how many times. I mean, I got a call a few years ago from a woman. She was the sister of a soldier, and she wanted the police. She wanted him removed from her house immediately because she had sent her daughter in to wake him up, and he woke up in a dissociated state, didn't know where he was probably thought he was back in Iraq, and he had the daughter by the throat up against the wall. And so this totally freaked out the entire family. But in working with that family really closely, we were able to find out, okay, who are the support people? Who can actually support him? What can we do in his community that can help support him? And how do we get him to the point where, like, he's a safe person to be around? Do we, someone who's resistant to being assessed, needs medication, doesn't want to go see a therapist? I mean, you've got a puddle there that needs to be waded through. But for the person, the family support person who makes the conscious choice to be the support for the traumatized person, is on many levels accepting the trauma and helping the person accept the trauma, but in doing that is also can be traumatized, and they have to work with their own trauma. Pay attention to your reactivity. If you're feeling feelings of paranoia, if you're losing sleep, if you're having trouble eating, if your eating pattern's disrupted, if you can't sit down and relax, if when you go into a restaurant you can't have your back to the door, any of those things, that you may be experiencing some secondary trauma. It's very similar to primary trauma, but you're experiencing on behalf of the other person's experience. And much of it is like in therapy, we call it transference and countertransference, but in your family system it can be projection, because you may project onto the person who experienced the trauma what you're feeling and your response is, when really the person has a different feeling and response. So, but in your family system, you have the capacity to hold this trauma and to help each other heal together. And because you have the compassion to call and ask the question, what do I do if I'm experiencing secondary trauma? And, if you're losing sleep, if you're bolting, which I call it bolting, it's actually like sitting straight up in the middle of the night and you don't know why, because there wasn't a loud noise or anything, but you're hyper alert. And if your value system is experiencing significant changes, where you used to feel like you were super religious or super patriotic or super something else, and but now you're questioning all of that because someone that you care about has been hurt, you may be processing the trauma in a different way and experiencing secondary trauma. And it's very important for you as the support person and for yourself to be able to identify that and get the counseling you need. And there are really good trauma therapists in the Bay Area. This is an incredible area. And if you need referrals, you could probably call Swords, and they could probably give you some good referrals. You could also go on the AAMFT website, aamft.org, because that's the American Association of Marriage and Family Therapists, and they have a listing, and you can look for a therapist that works with trauma and find out who's available. How's that? Any more questions?
That was great. Yes, we do have another question. What reporting options does a survivor who was assaulted on a drill weekend have?
Stateside, they weren't deployed, right? They're a reservist or a guard.
On a drill weekend, so it would have been stateside.
Then you report to you report to your local police. You know, you actually have the protection. I think I had a slide on that. We've been asked that a number of times, and we've checked with different policing agencies, and they've said, like, I mean, you can let the command know if the command's not involved in it during the drill, but you can report locally. If you're stateside, you're not actively deployed, and you're doing a drill, you can report to your local police, and there are severe repercussions. And, you know, that may be a preferable method. But if you don't want, you need to make a conscious decision about pressing charges, you know, because things do get publicized and they become public record. So all of those considerations are to be thought through. But you can report to your local police if you're on a drill weekend and something happens. And, you know, I mean, I work in half the time I work in another state where there's no bases, and it has huge deployment record, and lots of stuff happens, you know, within the state, and local police are involved, and local support organizations do get involved.
So Jessica had a couple follow-on questions. She wanted to know if UCMJ applies, and that's Uniform Code of Military Justice, and whether UCMJ has jurisdiction at all.
If you're, I can't answer that because I would be guessing at this point, but the Guard and the reservists, I mean, it's different too, because like if you're, you know, even within the Guards, it's different. But I think everyone's subject to the UCMJ who's in the military on any level, but I would actually have to read the entire UCMJ to see where that oversight is. But that is a really good question. Now I'll probably print out the entire UCMJ and try to figure it out. But I've been told that state law officials, like if something happens, it's considered like a civil issue if something happens. Criminal, definitely, but yeah, I mean, chances are, and that's one of the things that came up at one of our trainings in another state. Everyone was reservists, and they may never be deployed, and they may never be on a base when something happens. So they're more likely to turn to local officials. But I do think that I do know that also reports are filed within the military. So, and they make choices, you know. But if you are assaulted and you're on a drill and you go to local police, that's not a restricted report. You don't have the options of restricted and unrestricted. It's probably going to be in the newspaper.
Thank you, Elizabeth. Yeah, that's the last question for now. Jessica, I'm going to respond with some additional information. But if anyone else has any additional questions, please post them in the questions block on the right-hand side of your webinar panel. You can continue, Elizabeth.
Okay. I had just gotten a question on my phone, so I was trying to trying to text back to. Okay, sorry about that. I also wanted to tell you guys something. You're people who are in the Bay Area, in the San Francisco Bay Area. You guys have access to the Bay Area Military Law Panel, which is one of the most progressive, best groups of military law officials in the country. I mean, these people are really, really good. And if I had a question, a legal question like the one I was just asked, which I didn't have the answer for, I would call a member of the military law panel, the Bay Area Military Law Panel, because they're very, very good, and they've handled the gamut of cases. And I believe they're all members of the National Lawyers Guild, but also they do focus some of their pro bono time on military cases. And one of the attorneys specializes in recruitments that happen underage, and you know, like the delayed enlistment program, or people where the parents sign them off underage, like either you do this or whatever, and so they're recruited when they're underage. So they do have all kinds of specialties within that group. It's a really good group of attorneys that you have access to here. So I would definitely contact them. If I had a legal question, and that is a legal one, but here you have bases too, so I don't know if bases, that's one thing that came up while I was trying to answer that question, is whether or not if something occurs during a drill, and if the drill happens on the base, then I think what happens on the base would take precedence, that they would have the legal right to kind of take over that case. But I don't know. That's a legal question. I'd have to ask a military law attorney that one. Maybe someone will call in and give us the answer. But I would like to talk about a case where a woman was sexually assaulted, and then charges were brought against her. And this is a really unfortunate case because charges were brought against her for having sex with someone when she was married to someone else. And that's another time when the UCMJ can be really confusing and counterproductive, because they don't have the parameters of the reality of what people have to deal with. Often, like I've read tons of DOD directives, and I used to print them out by the hundreds and take them home and study them. And I would go, well, these don't even apply to the people I'm working with, or these don't even come close to what I'm dealing with in trauma. And in this case, this person temporarily, not permanently, but temporarily lost custody of her children because of this. And this was a time when the military court reported to the civilian court that she had these charges against her, and then she was investigated by social services. And I don't know that happens often, but this was a very extreme situation as far as custody and safety of the children, and where a survivor was brought charges against her for having been assaulted, and she lost the custody of her children temporarily. It was a really rough time. In the last 5-6 years, we've learned an awful lot about how to protect and how to advocate for survivors of military sexual trauma that we didn't know. We really didn't know. And we were looking for answers. And I think there probably people at Swords had a lot more answers than I did, because early on I was turning to Swords to Plowshares to ask them questions about different cases that would come up. But I do think you have tremendous resources here in the Bay Area. therapeutic, clinical, and as well as legal. I live in another state, and I rely on the resources here. So I think you guys can call Swords to Plowshares, and they can steer you in the right direction. I feel like I'm done with this presentation.
Hi, Elizabeth. There aren't any further questions, so we can just go ahead and move on at this time.
Okay.
Thank you, Elizabeth, for your informative presentation and the timely questions. At this time, we would like to remind the grantees that the next webinar will be 11 a.m. on May 22nd, and the topic will focus on domestic violence in the military and veteran families. Our second regional meeting will be held in Los Angeles on June 25th. Let me make sure there aren't any last-minute questions. Thank you, everyone. This concludes today's presentation and discussion. We thank you for your presentation, Elizabeth. We'd especially like to thank you, our participants. Please note that each of you will receive an email with a web link to evaluate this presentation. Your feedback is important to us, and it is greatly appreciated. Thank you again for your time. This concludes the webinar. You may now disconnect.